Okay, dear friends and colleagues, welcome to join this lunchtime seminar series. Today, we are very happy to invite our colleagues, Dr. Michael Yeung, to share a topic on shining light on the brain research and clinical implications. So thank you very much for joining us. I know some of you are still working in your workplace, having lunch, but anyway, thank you for joining and take this opportunity to know each other and share what we want to do in terms of neuroscience. Before we start and invite Michael to share his seminar information today, I would like to give a very brief introduction about Dr. Michael Yeung. Michael actually obtained his bachelor and also PhD in psychology, especially in neuropsychology from Hong Kong U. Later, he went to work as a postdoctoral researcher in Canada at the McGill University Montreal Neurological Institute. Before joining us, he is now our RAP Research Assistant Professor. His research interests focus on the function of human frontal lobes, especially executive function, and also social-emotional function and decision makings. Her interest is very diversified, covering the full lifespan and different populations in terms of healthy and also pathological diseases. So that will be a very interesting topic he is going to cover because clinical implication probably is one of your concerns. He definitely would like to share a lot about his experience, research ongoing, and also how he can integrate his research into clinical practice. I'm sure you will find interesting. So without further delay, I'd like to invite you to give a round of applause to him and invite him to give a talk. Okay, Michael.
Hi, thank you very much for the introduction, and I'm going to share my screen. Okay.
Yes, please start.
Yeah. So today in this talk I'll talk about the research and clinical implications of shining light on the brain, and I've been shining light on people's brain or head for several years in my research, and I'm a psychologist, and I have a little training in occupational therapy or physiotherapy, and but today I'll try to talk more about the rehabilitation, the use of the implication of shining light on the brain in rehabilitation settings. And in medical sciences, we use some sort of energy to understand or intervene the human body. For example, we use light, we use sound, we use electricity and other forms of energy. And today, I'll focus on light energy. So, okay, so the application of light in it can be found in almost every corner of medical and biological sciences. For example, here you can see that we're no stranger to this. This is infrared thermometer, and it's used for taking temperature. It's for screening fever. And here is another application of near-infrared light. It's this for diagnostic purpose. It's here it's an example of using near-infrared light to detect breast tumor and diagnose breast cancer. And here is another application of near-infrared light. It's shining near-infrared light on the body in order to speed up tissue repair, increase blood circulation, and reduce muscle pain. And here it's more related to research. It's the application of near-infrared light in understanding of human physiology. This is a technique known as near-infrared spectroscopy. It measures muscle oxygenation related to muscle activity. So here are the examples of shining light on the body for diverse purposes. And as a psychologist, I'm interested in how the application of light in neuroscience and psychology. And in fact, there's been an increasing interest in using a near-infrared light in the study of brain function. And this can be broadly declassified into two categories. So when near-infrared spectroscopy is applied to the study of the brain, it's known as the functional near-infrared spectroscopy, or FNIRS. And for the rest of my talk, for convenience, I'll use NIRS to refer to FNIRS. And another broad category of this application in neuroscience is photobomb modulation, or formerly known as low-level light therapy. And in this talk, I'll focus on NIRS. It's it's an emerging it's an emerging promise in neuroscience research. And toward the end of the talk, I'll talk more about photobomb modulation. It's an intervention tool. The NIRS is a neuroimaging tool. And today's talk will be aimed at a broad audience. So if you're a researcher, it may be of interest. You may find FNIRS to be interesting, and if you're a clinician, you may find both to be interesting. And now, the aim of this talk is to talk about different uses of near-infrared light in our understanding of brain function, and to intervene in the intervention of brain function. So there are already different types of functional brain imaging techniques, and most of us are probably already very familiar with this technique. This is EEG, or electroencephalography. It measures the electrical activity of the brain, and it's easily accessible because it's of low cost. And one unique feature of EEG is that it has a high temporal resolution, which means that it can distinguish neural events that are milliseconds apart. However, EEG it is a poor spatial resolution. It means that signals picked up at the channels can originate from a large population of neurons. So it may not be. So if you're interested in studying brain activity in certain area, then you may use other methods such as fMRI and PET. So here is an fMRI scanner, and here's a PET scanner. And what's unique about fMRI is that it provides information about brain structure, and it has an excellent spatial resolution. So it can distinguish brain activation that's millimeters apart. And the PET is also useful in clinics. Its main advantage is that it can measure the metabolism of brain cells, as well as to find out the distribution of neurotransmitter receptors in the brain. However, these two techniques, both fMRI and PET, are quite expensive, and they also place demand on participants because they have to rely on the scanner for a certain period of time in enclosed space. So it may not be suitable for people who are claustrophobic or who move a lot. And here is an example of an FNIRS system. So NIRS has intermediate temporal and spatial resolution. So it's somewhere in between EEG and fMRI. And it can measure activity, brain activation in certain from localized brain areas. But there's some disadvantages. It doesn't provide information about brain structure it can only measure brain activity at the cortical surface. However, it's as you can see, it can be used in a very natural setting, so people can you can take the measurement while people are sitting, and so today I'll discuss based on these the advantages of NIRS. I'll talk about how this technology can be applied into the study of the brain and in the intervention of brain function. So here's an introduction to NIRS, because some of you may not be familiar with this technique. So FNIRS makes use of at least 2 near-infrared lights, and so lights are delivered from some emitters or sources, and the lights then penetrate the skull, cerebrospinal fluid, and brain tissue in a banana-shaped trajectory. Some photons are scattered along the way, but others manage to exceed the scalp and get detected by some detectors or receivers. And so it's based on the principle that when neurons are active, there's an increase in oxygen consumption. There's a slight increase in oxygen consumption, but that leads to an large increase in cerebral blood flow. So if you take both together, you see that brain activity leads to an increase in oxyhemoglobin concentration, but a decrease in the oxyhemoglobin concentration. So here's a diagram illustrating this phenomenon. So when there's stimulation, oxyhemoglobin concentration goes up while the oxyhemoglobin concentration goes down. Since the optical properties of these 2 chromophores are different at different wavelengths, so every NIR system uses at least 2 wavelengths to make measurements. There are many NIR systems exist. Some are bigger, some are smaller. So here is a very widely used system in NIRS research. It's the Hitachi system. The UBSN at our university has this machine, an older model. This is a newer model, but I don't think there's a large difference between the older and newer model. So it has a very big main unit, but it can measure activity from a large area of brain area. And the one in the middle is the one that I use at the CHK. So I primarily use this machine in my NIRS research. It compared to Hitachi system, it has a smaller main units, so it has a better portability, but it's not completely portable because there are wires and that they're connected to a computer. And here, with the advancement of technology, there's been an increasing number of wireless NIR systems. So this is an example, and there is complete wireless. You don't see any wire here, and people can wear it while performing some tasks with their brain activity measure using a tablet or a laptop computer. So to get you more familiar with this technique, I'm going to show you a demo using the verbal fluency task, which is widely used neuropsychological test for executive function and language, and has been shown to activate the prefrontal cortex. So here, it's a data set that I acquired 2 weeks ago. I was testing a patient, a person, and here you can see I'm asking the participant to rest, and here you can see the color is changing. White means it's the baseline. It means no activation. Red means activation, while blue means deactivation. So you can see while the participant is resting. There's not much change in the hemoglobin concentration. So now I'm asking the patients to repeat a phrase to say 1, 2, 3, 4 slowly. It's a control condition for like mouth movement. And there's a little bit activation on the right side, but it's not pronounced, and it gradually returns to the baseline. So there's not much increase in oxyhemoglobin concentration during the repetition of a well-known phrase. It doesn't place any cognitive demand on the participants. So now I'm asking the participant to rest, to relax and sit still again. So the color for most part is white, which means that it's at the baseline level. So the participant is still resting. In 10 seconds, I'll ask participants to generate as many words from a category, fruits, within 30 seconds. So now the participant is still resting. Okay, I'm asking the participant to generate words. Here you can see some activation at the beginning. Participant is keep saying some words like mango, apple, orange. So as the word stock becomes depleted, the cognitive demand increases, and that leads to a greater increase in the activation. So you can see the prefrontal cortex now is all red, means that there's a massive activation in the prefrontal cortex. The participant is like paying much effort in generating words, and now I'm asking participants to relax again. And the aim of this is to see if the brain activity level returns to baseline. And then you can see that it's less red for most parts of the prefrontal cortex, which means that the brain activity is gradually returning to baseline. Although it does not completely return to baseline, it's still a little bit red. Okay, so that was the demo. And here you can see the time course of the brain activity. So you can pay attention to this figure at the left top corner. It shows the change in oxyhemoglobin concentration over time. So there's a little activity during the initial rest period, and there's a little activation during the phrase repetition, and there's little activity during rest. But when I asked the participants to generate as many fruits names as possible, and you can see that most channels show increased activity, and the activation gradually returns to baseline level after the task. So here's another index generated by NIRS. It's the oxyhemoglobin concentration index. Is less. Some research studies suggest that it's less sensitive. It has a lower signal to noise ratio. So even though there's a slight decrease of in the oxyhemoglobin concentration during the task, is not very pronounced. And it's the sum of the two indexes, and it represents cerebral blood volume or cerebral blood flow. And here you can see that cerebral blood flow in most channels increase during the task. And here, well, people usually just analyze the two, but I'm just showing you a more complete picture the hemodynamics during the verbal fluency task. And here's the difference between the two, which represents cerebral oxygenation. And you can see that it increased during the task. Since it was part of testing, so I asked the participant to do the same thing 5 minutes later. So there's the first time and it was the second time. And in general, you can see the pattern, it's still there, although it, overall, the activation level is not as much as the first time. The pattern is still there. And if you look at the spatial distribution of the activation, so you can compare the blue and the red bars. On both occasions, the activation is more pronounced in these channels, and there's a intermediate activation here in these channels and little activation in these channels. And this is a graphical a presentation, 2D presentation. I projected the signals to the brain, and here you can see the spatial lobe distribution, and for both repetitions, the participants show activation primarily in the frontal polar region, especially in the right frontal polar region. So the pattern is similar, but some research shows that this varies from individuals, but at the group level, NIA's signals show good test-retest reliability. So that was an example of a task that relies on the frontal lobe. But we know the frontal lobe is a large area, and it serves different kinds of functions. So the frontal lobe, it's the full part of the cerebral cortex, and it can be broadly divided into two parts: the motor area and prefrontal cortex. The motor area is primarily responsible for motor functions, while the prefrontal cortex is primarily responsible for a diversity of functions, including attention, executive function, emotion, social behavior, decision-making, memory, language, and so forth. So if your research interest falls in one of these categories, then NIAS can be a good tool to study brain activity during the tasks of these functions. And I'm talking about the frontal lobe specifically because NIAS application has been mostly confined to the frontal lobe because the frontal area yields a better signals. There's a little hair in the forehead compared to other parts of the head. But with the advancement of technology nowadays, then many NIAS systems can be applied to non-frontal areas, and there's even whole head system that take measurements over the brain. Okay, so up to now, I think you have developed a rough understanding of an idea of how NIAS works. And in the following, I'll discuss different uses of this technique in research settings. So I'm interested in the lifespan development of executive function and other frontal mediated functions. And it can be used to understand the neural basis of cognitive function, especially its development and aging. So here we know that different types of cognitive functions improve during development but decline over age. Not all cognitive functions decline over age. Some are preserved or get even better with age. But then the developmental and age-related trajectories for different cognitive functions are different. And NIAS can be a great tool to understand the development of these functions because of its well tolerated by people, and it's resilient to motion artifacts. So NIAS can be used to identify to study brain function even in infants and toddlers or preschoolers. And it can be, and some children may find NIAS more comfortable with, especially young children and some older people. And the goal of this is to characterize the developmental trajectories of different functions, and the findings can be used, can serve as to better understand the origin of cognitive impairment in mental disorders, and may serve as neural markers for healthy development. So it can be used to understand mental disorders, especially that originate from abnormal brain development and aging. So here, let's take an example. So interference control is a core aspect of executive function. It's crucial for goal-directed behavior. And the interference control is usually in laboratory settings measured by the Stroop and the flanker tasks. So in the Stroop task, the goal is to name the color of some words. And for the flanker task, the task is to identify the direction, pointing direction of the central arrow. So in the congruent condition, there's no conflict, but in the incongruent condition, there's conflict. For example, in the Stroop task, the color of the word doesn't match with the meaning of the word. So in order to name the color, you have to inhibit the semantics related to the word. And for the flanker, the direction, the pointing direction is different for central and other arrows. So you need to focus on the central arrow while ignoring other stimuli. Some lesions, this lesion study shows that these two tasks are dissociated in different parts of the brain. So here's a lesion study comparing the effect of damage to the left and the right lateral prefrontal cortex, and it shows that left frontal damage impairs Stroop task performance specifically, while the right damage to the right lateral prefrontal cortex impairs flanker task performance specifically. So here we can see a double dissociation finding, and this is also supported by neuroimaging findings. So during the Stroop task, the left side of the frontal lobe is primarily activated, while during the flanker task, the right prefrontal cortex is predominantly activated. So I'm interested in finding out the developmental trajectories of these two forms of interference control. And here's a new study that was carried out recently. It's we recruited a group of 7 to 16-year-olds. These are healthy children and adolescents. And we use two tasks implemented with a block design. So there is an incongruent condition and a control condition. And for some reason, we use a neutral condition for the Stroop task as the control condition. So we found activation as a group. There's activation during this period, the incongruent block. So there's a conflict-related activation. And we found that age correlated with better conflict resolution ability indexed by the interference score between the control and experimental conditions. And age also correlated with greater conflict-induced medial prefrontal activation for both tasks. And here is the scalar plots. And there is the age on the x-axis and the mean change in brain activity on the y-axis. And here you can see that age correlates most strongly with activation in the medial frontal region for both tasks. And if you look at the relationship between these relationships between age, flanker, and Stroop, and you can see there's a little overlap between the flanker and the Stroop variables, so that although both task variables are related to age, there's a little overlap between them, which it's applicable to both behavioral and imaging data. And that suggests the developmental trajectories of these two forms of interference control may be dissociable or at most weakly related. And so the implication is that it means that it's possible to have one form of interference control impaired while sparing the other one. And rehabilitation may rely on this fact to employ the intact ability to compensate for the impaired skill. So here's application of NIAS in aging. It's a systematic review of more than 100 studies, and they found that older adults have lower frontal oxygenation arrest compared to younger adults, and that may be due to age-related deterioration of the cerebral vasculature. And we also found altered frontal activation patterns during different kinds of cognitive and motor tasks. And such that when the task demand is low, older adults shows a sign of compensation. They tend to recruit task unrelated regions to compensate for the decline in task related regions. And because of the possible existence of compensatory strategies. But when the task demand is high, older adults show signs of under-recruitment of the brain, and that is could be due to the non-existence of compensatory strategies. It's just too overwhelming. And these findings are in general compatible with aging theories derived from Fmri and PET studies. But there are some things that are of note is that NIAS have been widely applied to the study of motor functions. So here you can see that it's mostly applied to the study of gross motor skills, and especially walking, just walking or walking while performing a task or the dual task scenario. So that illustrates one of the unique properties of NIAS is that it's quite resilient to motion artifacts. So it is a great tool for studying motor function. It's also quite frequently applied to resting because it's well tolerated by people. It can be used to study the functional connectivity, how brains interact with each other while resting. But for most NIAS systems, we cannot measure the absolute concentration of oxyhemoglobin. Most existing commercially available systems measure changes in oxygenation. So the application to resting, it's mostly confined to understanding functional connectivity. So here's another application of NIAS in research is that it can try to explain normal variations in cognitive and brain functions. So we know that cognitive and brain functions are different in mental disorders, but we know that there are large individual differences in cognitive and brain functions as well. And so one application of NIAS is that it can be widely used to identify factors that protective and risk factors of our cognitive and brain dysfunction. So then it can have public health implications because policies can then be made to promote protective factors and to make policies that discourage risk factors. So in my research, I often use the MBAT task as a probe for prefrontal functioning. especially comparing the high cognitive load condition with a low cognitive load condition, such as a 0 back and the 3 back. The 3 back places a large amount of cognitive demand. And by comparing the two, you can isolate activity due to working memory or cognitive activity. And the MBAC task has been shown by Fmri and PET studies that it consistently activates the prefrontal cortex, certain areas of the prefrontal cortex, and damage to certain parts of the brain will impair MBAC task performance. And we know that TMS and Ddcs, the brain stimulation methods, will change MBAC task performance. So in my research, I often use it as a probe for prefrontal functioning. So here's a study to understand individual differences. So we know that sleep is important for cognition and for brain health. If you're deprived of sleep completely for one night, you have trouble paying attention, you're less able to make good decisions, and problem-solving ability also suffers. And we know that the brain, after one night of total sleep deprivation, the metabolism in the brain decreases dramatically. But most sleep research focus on total sleep deprivation. In daily lives, sleep restriction is more common. So most of us are more likely to get insufficient sleep rather than not getting any sleep altogether. So in one study, I looked at the relationship between the duration of sleep the night before and prefrontal functioning probed by the MBAC task. And here you can see that there's a positive correlation between brain activation and the sleep duration the night before. And it's consistent for both the oxyhemoglobin and the oxyhemoglobin indexes. So that's suggestive of like remeasuring brain activity. And the implication thus is that one thing of note is that there's sleep duration did not correlate with working memory performance. So the results suggest that brain changes in brain function may precede cognitive impairment as a result of sleep deprivation, and that it has a public health implication because not getting sufficient sleep may lead to differences in brain functioning. It may be associated with poor frontal functioning. In my review in aging, we've identified several protective factors and risk factors for hypofrontality to reduce frontal oxygenation levels or changes in older people. And the protective factors include aerobic fitness, sleep quality, education, social activities, and the risk factors include hypertension, diabetes, hyperlipidemia, and perceived stress and fatigue. So, so we can, based on these findings, we can then make design interventions that target these factors. And one promising approach seems to be cardiovascular exercise, because aerobic exercise is associated with so many protective and risk factors here, that are listed on this slide. Okay, here's another application of niacin research is to understand disease populations. So many psychiatric disorders and neurological diseases have abnormal brain function. The brain structure is different from healthy people, and the metabolism and the functioning are also different. And then I'm interested in autism and mild cognitive impairment and dementia. So by one property of Ddcs is that it's quite well tolerated by children with autism and older people with mild cognitive impairment and dementia. And it's also low cost, so it has the potential to identify neural markers for these diseases to facilitate clinical diagnosis. And these neural markers can also shed light on interventions for these disease populations. So here is an example. It's an autism research study using the MBAC task, and we compare teenagers or have typical development, healthy teenagers and teenagers with autism. And we found that all teenagers show bilateral prefrontal activation on both sides, not much activation in the middle. But for autistic teenagers, they show activation primarily on the right side. So when you compare the activation level between the two sides, autistic individuals show significantly greater lateralization during the MBAC task. And what's more interesting is that within the ASD group, there's a positive correlation between the extent of lateralization and working memory ability. Because of the role of the right hemisphere in visual spatial processing, the findings may suggest that autistic individuals may successfully compensate for working memory by employing visual spatial strategies, and that may have a rehabilitation implication. So we know that autistic individuals don't use language in the same way as healthy people, and they are less likely to employ internal speech while performing some cognitive tasks. So for autistic individuals who show poor working memory, we may try to encourage them to use visual spatial processing to compensate for verbal, deficits in verbal functioning. Here's another application of NIAS in clinical population, MCI, the mild cognitive impairment. It's exactly the same task used in the previous study I showed you earlier. And we found that healthy older adults show bilateral frontal activation, just like healthy teenagers. But for older people with MCI, they show little activation across the prefrontal regions. And so reduced activation during working memory tasks may be a neural marker for MCI, and then it may be used for early detection of dementia. And so it shows that the different disease populations have different patterns. They show different alterations of frontal activation pattern. So in MCI, these patients show underactivation, but for ASD, they show changes in levelization. Here's a recent systematic review of 66 studies with MCI and dementia patients. And we found MCI dementia, the pattern is that the severity of cognitive impairment correlates with the reduction in frontal oxygenation levels and changes during tasks or at rest. So here you can see that NIAS has mostly been applied to study of verbal fluency, retrieval, or memory function. And because these two abilities have been shown to be reliable predictors of future cognitive decline. But MCI dementia are also impaired in other cognitive, social, and emotional functions. And for over the years to come, NIAS may be more applied to the study of other aspects of functions in MCI and dementia. So we can also take advantage of NIAS to study the neural basis of social interactions, especially when people are engaging or cooperating on some tasks. So it's may be a promising tool for studying parent-child diets, teacher-student diets, and child and the peer relationships. And we can do that with EEG as well. But this is hyperscanning. And one advantage of FNIRS is that it can be used while people are engaging in some other tasks, because NIRS is more resilient to motion, so they're more it's more suitable for studying like cooperative motor performance. But the limitation is that NIRS can only measure activity at the cortical surface. It cannot pick up signals, brain activity from deeper brain regions. Because of it's quite free from interference of the electrical and magnetic field, NIRS can be used in combination with other neuroimaging tools or physiological tools. So here's a study combining NIRS and pupillometry. So it's a portable eye tracker and looks like glasses. And here's the NIRS setup. And so the question here that is asked in this study is the contribution of the CNS, the PNS to cognitive processing. So we know that the prefrontal cortex is activated during some cognitive tasks, like during the MBAC tasks, and it may reflect cognitive processing or increase in arousal. The pupil diameter is processing measure for arousal, so we can see whether this increase in prefrontal activation reflects change in arousal. So here are the results. As expected, prefrontal activity increases during the feedback during the more difficult condition only, and the pupil dilates only during the more difficult condition. And we've looked at the correlation between the two. There's a little correlation between them on the feedback task, on the most during in high cognitive demand, but there's a correlation between the two during the easy zero-back task. Here, the correlations, the relationships are present at both the group level and at the subject level. And it means that when there's a little cognitive demand, there's an intrinsic connection between so PFC activity mostly reflects arousal level or systemic physiology, but when the cognitive demand is high, prefrontal activation mostly reflects cognitive processing. And it also have implications for understanding of mental disorders, because brain dysfunction is impaired in many mental disorders, and emotional motivation are also impaired in some mental disorders. So this study shows that the combination of NIRS and pupillometry may provide unique complementary information about physiological processing during some cognitive tasks. Okay, so now I'll bring attention to rehabilitation. So I talk a lot about the application of NIRS in research. So here, some suggested uses in rehabilitation. Okay, so NIRS can be applied to facilitate preventive healthcare. So in rehabilitation, we focus a lot on identifying people who are at risk of some adverse outcomes. For example, in engaged rehabilitation, we want to prioritize rehabilitation for older people or other people who are at risk of falling. So here is a study identifying risk factors for risk risk. So it's a new study looking at it's found that it looked at prefrontal activation during some walking tasks, and it's a longitudinal study. It found that prefrontal activation during dual task walking predicts falls in 166 non-demanded older adults over a mean follow-up period of 3 years, such that each SD increase in prefrontal activation is associated with a 32% higher fall risk. What's more interesting is that this prediction remains significant after controlling for other demographic factors, cognitive medical statuses, and the cognitive performance and the previous fall history. So these are known, some of these are known risk factors for fall in older people. And this study shows that FNIRS measured brain activity during dual task walking can provide additional information for predicting fall risk in healthy people. So it remains to be determined which combination of risk factors are the most predictive of falls. So NIRS can also help to clarify the mechanism of rehabilitation strategies. So it helps you review the neural mechanism of rehabilitation programs. Here, we know that with some research studies show that feedback can improve both performance, and here's a study looking at cycling in stroke patients with hemiparesis. And there are 3 conditions: the passive cycling, which means the pedals move themselves. So it doesn't have to, the participants don't have to apply force. And there are 2 conditions for active cycling with and without feedback. So in the feedback condition, participant can cycle while receiving feedback. NIRS measurement is taken from motor and parietal areas. And it found that with active cycling, speed feedback did improve cycling performance and increase premotor cortex activation on the unaffected side, such that feedback delivery can help to recruit additional brain regions to compensate for the affected motor area. So it shows that its feedback improves cycling performance through the recruitment of for neural compensation. And it would be interesting to see whether like the TMS over the unaffected, because it's a feedback related improvement associated with increased activation on the unaffected side. So about stimulating the unaffected side using like TMS or Ddcs. And there's some studies show that resting Fmri studies showing the resting state functional connectivity between the 2 hemispheres is associated with motor recovery. And so NIRS can be used to look at whether there's a change in functional connectivity between the 2 hemispheres during some motor rehabilitation programs. And NIRS is especially suited for this purpose because, as I said repeatedly, it's quite resilient to motor movements. I'm going to skip this. Is another example. So NIRS can also be used to monitor intervention outcomes, especially interventions that involve movements. So here's an example looking of a NIRS study looking at the effects of Tai Chi Chuan training on inhibitor control in healthy older women for 8 weeks, 3 days per week, and 45 minutes per session. And inhibitory control is assessed using a flanker task with congruent and incongruent blocks. And here, after 8 weeks of training, only the training group showed improved task performance in the difficult condition. So here show the results of the changes in oxyhemoglobin concentration in different prefrontal areas, and it showed that only in the Tai Chi group that the prefrontal activation increased after training. So there's a little change in the control group. So Tai Chi Chuan training may improve inhibitory controllability and increased prefrontal activation. So it may lead to a better recruitment of the prefrontal cortex, or it may reflect that because the training group now understands the task better, they perform better. That's why they have larger, the prefrontal cortex is more engaged during the task. As I said earlier, NIAS is quite free from electrical and magnetic interferences, so it can be used to understand the action of brain stimulation, as well as the individual difference in the retreatment response. So there's been an increasing interest of applying brain stimulation to improve cognitive functions in mental disorders. And recently we've seen several systematic reviews reporting benefits of TMS and TDCS on cognitive functions in autism, ADHD, and Alzheimer's disease. But these systematic reviews also identify considerable individual differences in treatment response. So NIAS can be used to use concurrently with TMS and TDCS to understand the action of brain stimulation. So it can help you identify what's happening during the stimulation. And this is quite unique for NIAS because for EEG and Fmri, these techniques may not be compatible with these stimulation methods. But it's worth mentioning that it's not without technological challenges. For example, in TMS 7 years setup, it's challenging to find out the optimal configuration. So how the TMS core is placed in conjunction with NIAS systems. It's less problematic for NIAS TDCS application, but there are still technological challenges that have to meet before we can do that. Here's another application of NIAS in rehabilitation. It opens a new venue for brain-computer interface, and it's especially good. BCI can be a great rehabilitation approach for patients with severe motor deficits or for patients with ALS, or also referred to as lock-in syndrome. The idea of BCI is to use brain activity to control external devices, so in order to accomplish some goals. So we take, in a BCI setting, brain activity is taken for example, here using NIAS, and then the computer processes a signal and identify feature that's a predictive of an outcome, and then it undergoes a classifier, and the classifier returns an outcome. In this example, a binary motor outcome. So it's an on and off. It's then sent to an external device, so to control, to perform some tasks. So this diagram illustrates the control of a robotic arm. It can also be used to control like a mouse cursor on a computer. So patients have severe motor deficits can operate a computer. And this one is another application, BCI application. The commands sent to stimulate muscles using a muscle stimulator, so you can have to like overcome some obstacles in executing some movements. And here is so BCI is we can do that with EEG as well. It's in fact it is more well established in using EEG, but NIAS has the advantage of using localized brain activity, but it has a poorer temporal resolution than EEG, and its NIAS is based on the sluggish hemodynamic response. So it's EEG has a more reflects the online processing of brain activity. So the combination of EEG and NIAS can be promising for eBCI. Here's an example of application in stroke patients. So this study looks at brain activity in motor and parietal areas during paretic versus non-paretic hip movement preparation. It found that there's difference between brain activation while preparing paretic and healthy hip movements, and it's not confounded by EMG. So it's there's no EMG activity in either leg during preparation, and based on these signals, the train classify based on these signals, and it found that 6 out of 7 chronic stroke patients can the brain activity can distinguish these two types of preparation. So, but of course, you can see there's a large individual difference in the success rate, and BCI may be most suitable for patient 7, for example, which is 86% of accuracy of classification. So if it's connected to a robotic leg or prosthetic limb, it may be used to compensate for the weakness in the affected limb. So here, it is similar to BCI. It's for neurofeedback. It's based on the principle that patients can learn to change the brain activity through online presentation of feedback and reinforcement. And it's different from cognitive rehabilitation. Rehabilitation is that it's based on the assumption that normalizing brain activity can have behavioral and cognitive consequences. So participants in BCI in neurofeedback training, they look at their own brain activity online, and they reinforce if the brain activity is closer to the normal level. And there's one pilot study looking at the effect of 12 weeks of neurofeedback training on ADHD individuals. It found that this training significantly reduced ADHD symptoms immediately after 12 sessions. And it's not seen for other feedback training, but there's no significant differences among the groups, and they may be due to short duration or small sample size. But neural feedback training can be an alternative tool for mental disorders. It's also different from TMS and TDCS because this relies on patients themselves to self-regulate brain activity, while in TMS and TDCS, there is some external influence. It's based on external influence. Okay, I'm going to talk very briefly about the photobomb modulation. It's a means to intervene with brain function. So here, near-infrared light can be delivered to the brain to intervene with its function. Of course, the intensity has to be is to be strong, and it can be delivered via different modes. So for subfigure A shown here is called transcranial photobomb modulation. So it's delivering light directly on the scalp. And some cellular and animal studies have shown that near-infrared light can have very many physiological effects on brain cells. For example, it can increase blood flow, it can reduce inflammation, it can increase symptomatogenesis, and so forth. And the inflammation, reduced metabolism, cell loss are characteristics of many mental disorders. So photobomb modulation may help to reverse some of these adverse physiological events. And currently it's still at the experimental stage, but it's as shown benefits for diverse populations, including healthy adults, Alzheimer's disease, stroke, traumatic brain injury, depression. And so in a typical photobomb modulation therapy session, patients are just asked to sit and then place some device made of like LED or laser diodes to deliver near-infrared light. So here's a randomized sham control study with healthy older adults. So it's a one session of photobomb modulation set for 7.5 minutes. And we gave these people, we recruited 30 people, 30 older adults, when we equally divided them into two groups, and we gave some frontal cognitive tasks before and after intervention. So the stimulation sites in the prefrontal area and the parietal area. And these are really nodes of the frontal parietal network implicated in cognitive executive function. And we found that one session of our photobomb modulation improved the frontal cognitive functions of older adults immediately after stimulation. And there is interaction between a group and time, which means that the experimental group shows significantly higher improvement in both the flanker and category fluency tasks. And these are tasks of inhibitory control and mental flexibility. So here we demonstrated that one session of photobomb modulation could improve executive function in older adults. But it has more research has to be done in order to see if this effect, if it has benefits for MCI and other aging-related populations and other, as well as mental disorders who have cognitive impairments. So here's a summary of reasons why we shine light on the brain. It has numerous research and clinical implications, and that's due to the low cost, the resistance to motion artifacts, and its applicability in natural settings. And so NIRS can be widely used to accomplish different goals. But we have to bear in mind that it's not without limitations. It doesn't give information about brain structure, or it cannot, it has only a intermediate spatial and temporal resolution. And it can only measure brain activity at the cortical surface. And so I hope that through this talk, you know more about NIAS and Photobomb modulation, and you may consider using them in your research or clinical practice as an alternative neuroimaging tool and an alternative intervention tool. So I'd like to thank all of these individuals and my PhD supervisor, Professor Alex Chen, and members in that lab. And I also like to express thanks to our collaborators at CHK and PolyU. Thank you very much.
Okay, thank you very much, Michael. Thank you for interesting and very informative talks covering a wide range of research experiments and also clinical applications. Definitely, you shed a lot of light to our thinking. So we have some time for Q&A. We have about something like 70, 80 people. So I'd like to invite you to either raise your hand or you can actually type something on the chat box, and then we can ask you to raise your questions. And I try to group questions together if they are asking something similar. I also note that apart from many clinicians joining us, we have some colleagues from our departments, from our faculty, and also other departments. So welcome again. I'm David. I'm moderating this section. So I looked at our deans here. So Dean would like to say something or would like to give some comments before we move to other people.
Thank you, David. Thank you, Michael, for a very interesting talk. I think it's very interesting to see the various ways that you can apply NIRS, in research and also in the clinical practice. Yeah, I actually got two questions. The first question is to do with initially when you talk about the verbal fluency task, you found that the activities or the activation was lower in the second time when you did the task. Yeah.
Mm-hmm. Yeah.
Can you tell us how far apart were those intervals, like from the first test to the second test? So that's the first question. And the second question is, I'm interested in using the NIRS, right, to monitor the outcomes of intervention. And I just want to ask, from what you presented, it seems that you can use either the resting state, or not the resting state, but the resting period, right, or the one with the task. So in the literature, what do they prefer to use? Do they usually use just the resting condition, or do they use the task, when they're engaging in a task? So thank you.
Okay. So for the first question, well, there was part of a pilot testing of a new near system, and the second repetition was administered 5 minutes after the first repetition. It's not ideal. It's not an ideal way to test retest reliability because the interval is too short, and the participant probably it's the same task. First repetition is like
yeah. So I think there might be a bit of practice effect. So if the period is a bit longer, the activation might be similar.
Yeah, and some people have already done that in younger adults and showed that well, there may be some slight changes in the level of activation, but in general, the activation pattern is very similar. And it has been shown that in older adults, in younger adults, the test-retest reliability is good for up to like 1 year. It's based on the same verbal fluency task.
Yeah. Okay. And how about the second question?
Yeah, it's about the application in resting and task-based settings. Yeah. But usually, the commercially available systems are a continuous wave. So we have different modes of NIAS machines. And for most available instruments, they can only measure relative concentration of oxygen deoxyhemoglobin concentration, which means that so it's good for measuring tasks, right? You compare a task versus a baseline, like a resting period. So it's very good for identifying task rate activation. Yeah. So I would say, more than 90% of cases, NIAS is used to study task-based activity. But it can also be applied to study brain dynamics during the resting state, although it cannot measure the absolute concentration level. For example, as I said, you can measure the connectivity between different brain regions during the resting stage. And it's because you don't, it has little demand, cognitive demand on patients during the resting state. So some people try to use it to identify neural markers that they're easy to obtain for diagnosis, differential.
Okay, thank you. Thanks very much.
Okay, thank you for the question, David. So I'd like to invite any other comments or question you'd like to raise. Dear friends, here at PolyU or outside PolyU. Michael, I've got one question on research and one question on the clinical application. It seems to most of us that FNIS can be an alternative to MRI. And definitely it's less expensive, less troublesome in terms of setup. I think this is understandable. But in terms as a research tool, using the standard way to think about like aging, like the frontal lobe functions, what will be the trade-off or advantage of using FDS in comparison with fMRI? Because that is a technical question. Can different questions be answered in terms of aging using FDS as compared with fMRI? Can you enlighten us on this?
Okay, so many people draw comparison between NIAS and fMRI, and FDS has the advantage that is can be widely because it's of lower cost. It can be more widely applied in a large population, and that's good for identifying protective factors and risk factors for aging, and so that we can make like changes, policies that promote or discourage some like protective and risk factors. But NIAS there's a technical limitation about NIAS is that as we age, the head and brain structures also change, and that would affect a NIAS measurement. And without correcting for this factor can lead to like biases and inaccuracy in our conclusion. But there have been recently there are some ways to get around this, like we can correct age with some formula, and we can use like derive indexes that take into account age differences in brain structure and head structure. But I would say that if you want to use, if you're like on a limited budget and you want to apply neuroimaging tool to a large group of people, and you want to imaging tool that's well tolerated by people, then NIAS can be a better option compared to fMRI.
Okay, because we have few questions from other people, so I reserve my question first. One question is from Bolton, it's a straightforward one. He asked about the verbal fluency test again. He said if correctly, he found that the whole prefrontal cortex more active when participants perform the task. Supposedly, the medial PFC is also part of the task, negative network. So should we expect weaker activity? I think it's about the loop, the frontal, at the different part of the brain. It's also written on a chatbot you can refer to. Can you answer quickly on this?
Yeah. So first of all, that's only one subject. So if you look at my research study with autistic individuals, at the group level, autistic teenagers don't show significant activation in the medial prefrontal region, and but they show great activation in the lateral prefrontal cortex. So some people do show activation in the medial prefrontal cortex, but at the group level, there's little activation in the area. So it's difficult to draw any conclusion just from one subject. But I understand the point why you're asking, because the medial prefrontal cortex is a part of the task negative network, so we expect a weaker activity. Well, sometimes we see activation in like these areas, not because but it's a, like there's a technical challenge, and it may show frontal polar activity because there's an increase in skin blood flow. So as you're performing cognitive tasks, you're aroused, the skin blood flow to every the blood flow increases everywhere, and it may reflect this systemic physiology influence. And so when processing NIRS data, this have to take it into account, and there are some ways to get around this.
Okay, so we have two more questions. One is from Rutherford. I think it's more on the clinical side. He said, would it be reasonable to use FDS to assess cognitive load in motor learning within an adolescent population learning gross motor tasks? He mentioned an example, landing from a jump to avoid ACL loading in the knee. Is it useful to identify individual struggling with motor learning? I think it's very specific, maybe a PT or kind of motor training perspective using motor and cognitive side. Can you elaborate on this?
Yes, I'm not familiar with the motor learning literature, but NIRS has been used to a lot in looking at the effect of cognitive load during some motor tasks, like such as walking. And here you can see an example landing from a jump to avoid. I'm sorry, I don't know ACT loading in the knee, but although NIRS is quite resilient to motor motion artifacts, it's still sensitive to very, very gross like motor movements. So I would expect that NIRS is not a good way to, as to many other neuroimaging tools, to measure activity during jumps or like running, this kind of very intense motor activities.
Okay, I think nowadays many people try to merge together the physical motor training with cognitive loading. I think a lot of study. Actually, we have some presentation in next seminar talk about this cognitive load in motor training. Maybe we can learn more from Marco Pang later in 2 weeks' time. And last question is from Kwok Yu Yeung. I think his question is really relating to the light itself. What type of light is used in photobiomodulation? Is there any standard of using such instrument, example duration, intensity, or any contraindication? Question one first, okay? We have another two questions, another question two.
So it's about the photobiomodulation.
Yeah.
So what type of light is a near red to near infrared light? So the wavelengths of the light we use is like 600 something nm and 800 something nanometers, and they're delivered by LED, no, not laser diodes, but LED. And for the parameters, because it's still at the experimental stage, so we're still finding out the optimal protocol for photobiomodulation. And obviously it varies across mental disorders. So it's still, we still don't know a lot about the optimal protocol. And the effect of photobiomodulation on people with MSA dementia, there's some, I think 1 or 2 studies looking at the effect of photobiomodulation of dementia, but it's a pilot study. There's no control group, so we can't draw a very firm conclusion of that. And we're currently looking at the effect of photobiomodulation on MCI. So I'm happy to share more if I get more results.
Okay, thank you. And in fact, this question actually was another question I would like to ask is about the biomodulation on MCI, because it seems to be helpful if we can do something to prevent or slow down the decline process. But as you mentioned, it's still in the beginning phase. We look forward to more study at the same time, translating this into clinical practice. That would be quite amazing and an advantage to older populations. So I'm observing about the time. So I'd like to see is another question raised by you, either by raising a hand, tell me verbally or using the chat box? If no, I would like to say thank you again for your joining, and also my big thanks to Michael delivering such an interesting talk during lunch hour. So can we give him another round of applause to say thank you? So thank you for joining us. For those who are applying CPD, you will be informed by email to get a certificate. And announcement before we conclude, we have another seminar to be scheduled on 28th October. This is 2 weeks later, Wednesday. The speaker is Professor Michael Pang of the Department of Behavioral Sciences. His topic is on the effect of physical exercise to modify cognitive and psychosocial function in MCI and dementia. Again, very interesting, hot topic. So I love to invite you to join again next time. So thank you very much. And thank you for joining again, and have a very nice evening. Thank you very much. Bye-bye.
Thank you very much.
Bye-bye.
Bye.